Next, we're going to talk about coronary artery disease, angina, and MIs or myocardial infarction. So we'll start with talking a little bit about the normal cardiac or coronary circulation. You see on the picture here, I think this is maybe a CT, three-dimensional CT of the heart itself. And you can see on the outside of that heart all of the arteries that supply the blood directly to the myocardium. So you have the left main coronary arteries, that's this artery that comes directly off of the aorta. So as blood leaves the left ventricle, that newly oxygenated blood, one of the first places that receives oxygenated blood as it leaves the heart is the heart muscle itself. So blood is ejected out of the left ventricle into the aorta, and the coronary arteries that supply the blood to the heart muscle branch directly off of the aorta and quickly supply blood to that heart muscle. This is important because the continued oxygenation and sufficient oxygenation of the heart muscle is essential to maintain its functioning. So again, you can see them coming right off the aorta. So here's your left main coronary artery, and it branches into what we call the left anterior descending that runs all the way down to the apex of the heart. And then here is another artery that branches off the left main, the left circumflex branch kind of comes around and supplies blood to sort of the middle of the heart muscle and a little bit to the right ventricle. And then you also have the right coronary artery. So that branches directly off of the aorta too. So two branches off the aorta, one that splits and one that leads directly into what we call the right coronary artery. And this branch largely feeds the right ventricle of the heart and maybe a little bit of the posterior portion of the left ventricle. Okay. So when we think about the importance of blood flow and oxygenation to the heart muscle, we have to talk a little bit about how we balance oxygen supply and demand to the heart. So when we send blood to the heart through those coronary arteries, that myocardium extracts approximately 75% of the oxygen that's supplied. So a pretty high percentage, but not 100% of the blood, but 75% use is a relatively high oxygen use for tissues. But if we have something like an MI, myocardial infarction, that blocks one of these arteries, or if we have hypoxia, where we have an overall systemic drop in oxygen, or if we have a patient who is anemic and so has a reduction in oxygen carrying capacity, or someone with carbon monoxide poisoning, where oxygen on the hemoglobin has been replaced with carbon monoxide, those people will have a significant reduction in myocardial O2 supply. So again, those are things that can reduce that amount of oxygen that's supplied to the myocardium. The other side of this supply and demand equation is the demand side. So things that can increase the overall oxygen demand of the heart, meaning increasing its need for oxygen, are things like an increase in heart rate. So if the heart is beating faster, it will need and use more oxygen. Another piece is left ventricular contractility. So things like exercise or an increase in sympathetic nervous stimulation or the administration of what we call inotropic drugs. Those are all things that make the heart beat harder, increase its contractility. And the harder the heart beats, the more oxygen it's going to need to use. And the final side of that LV myocardial oxygen demand is what we call systolic pressures. So I'm just going to kind of point out on the picture here, those are things like afterload. So the harder the heart has to beat against pressure, that's afterload. And that can also increase overall demand. The other side of that is what we call filling pressures, and that's preload. We'll talk about those momentarily. So here's afterload and preload. Preload is the what we call the distending force. It's kind of like the force of stretch. So it refers to how much the heart fills before it contracts. So you can see that on the side of the picture, again, the volume of blood that's in the ventricles at the end of diastole. So the heart muscle relaxes, blood fills those chambers. The amount of blood that fills those chambers while they're in that low pressure state of diastole is what we refer to as preload, the amount we're kind of pouring in. Preload increases in patients who are maybe hypervolemic, they have too much fluid on board. It occurs in patients that have bad valves, and it occurs in patients with heart failure. But adequate preload is essential for good filling of the heart itself. Without adequate preload, if we can't fill the heart appropriately, we also don't get good stroke volume in the end. But preload, increased preload or increased stretch also increases the myocardial oxygen demand as we kind of stretch out the ventricles. The other concept is afterload. And afterload is the load the heart muscle pushes against to eject blood. So every time there is ejection of blood during systole, when that heart muscle contracts, that contraction has to push against force caused by generally the systemic circulation. So it's pushing blood out into the systemic circulation, and the amount of pressure in the systemic circulation determines the afterload, the amount that the heart has to pump against. So it's really the resistance the left ventricle has to overcome to get blood into the circulation. So things like hypertension or a lot of vasoconstriction in the systemic circulation, increased peripheral vascular resistance, will increase the amount of afterload of the heart. And it also increases the overall workload of the heart. So if we have high afterload, that also increases the amount of oxygen demand of the cardiac muscle itself. So if we're trying to reduce overall workload of the heart, we can reduce preload and we can attempt to reduce afterload as ways to bring down that workload and also bring down the amount of oxygen demand of those cardiac tissues. So with coronary heart disease, this is one of the things that can significantly reduce the O2 supply to the cardiac muscle. So it's impaired coronary blood flow, and it can cause things like angina or chest pain. As we lose blood supply, our body reacts to that ischemia by causing pain. This can lead to myocardial infarction or a heart attack. That long-term ischemia can cause heart muscle to die, and that is a myocardial infarction. It can cause cardiac arrhythmias or abnormal rhythms of the heart, which we'll talk about in another chapter. It can cause overall electrical conduction defects, again, that we'll talk about in another chapter. If damage to the heart muscle from things like infarction are significant enough, we can start to experience heart failure because of a reduction in myocardial contractility that happens as a lot of that heart muscle becomes damaged. And it can also lead to something called sudden cardiac death, which we'll discuss in the dysrhythmia unit as well. So in the picture, what you see here, this is a coronary angiography. So a picture of the cardiac cardiac arteries that supply blood to the myocardium. So this is the beginning of the right coronary artery, kind of right here. This is a catheter coming down. They're injecting a contrast dye directly into the right coronary artery. And right here, it just abruptly stops. All blood flow ends, and that's because there's some sort of plaque or thrombus or something that has developed in that artery that has prevented any blood flow from traveling further. So all the rest of the myocardium downstream from that blockage is no longer receiving any blood flow. no longer receiving any oxygen, and ischemia starts relatively quickly. You can see over on the right-hand side, this is the exact same artery. After that artery was opened, you can kind of see, maybe if your eyes are good, just like this right here, you can kind of see the difference in color. This is a stent that was placed in this artery, but now it's all nice and open, clear, and all of that blood supply is now getting to that myocardium. So that's what that artery should look like. So oxygen restored. So when we're evaluating coronary blood flow and myocardial perfusion, there's a lot of different kind of diagnostic tests that we might use. EKG is the most widely used. It can really tell us a lot about what's going on with cardiac blood flow. And it's an immediate kind of test that you can see. So it's very helpful and used significantly in the diagnosis of coronary artery disease. We'll talk a lot more about that as a diagnostic tool as we work through this unit. Other diagnostic tools are things like echocardiogram. This is an ultrasound imaging of the cardiac structures. So we use that a lot to, again, evaluate things like cardiac structure and function. There's exercise stress testing where we put someone on like a motorized treadmill or on a bike and try to increase their heart rate and work. So we're trying to increase kind of the stress on the cardiac tissue itself. And this is very important to test the heart under stress, because if you remember back to oxygen supply and demand, as we increase the workload of the heart by things like exercise, we also increase its oxygen demand. And so if we have a blockage in a coronary artery that would reduce oxygen supply, someone may not really notice, or there might not be visible changes to the myocardium if the workload isn't increased. But that lowered supply might become very evident when we increase myocardial workload under things like stress from exercise. So that's the purpose of exercise stress testing, is to determine if there's potentially a blockage that's lowering oxygen supply that becomes evident when we increase workload or demand. There's also nuclear cardiovascular imaging where we can basically infuse a radio dense kind of material that shows up on imaging that we can see when we stress kind of the heart. So that's just another type of evaluative or diagnostic tool that we can use. So it involves radionuclides that are kind of a non-invasive way to look for things like poor perfusion to the heart muscle or muscle dysfunction during either rest or stress. And then the final piece is what we call a diagnostic cardiac cath. If you think back to the last image where we saw that right coronary artery that was completely blocked, that's a diagnostic cardiac cath where we go in with catheters. We enter through usually the femoral artery. We snake up to the aorta just before it goes into the left ventricle, and we inject contrast dye right into the takeoffs of those arteries as they branch off of the aorta. And then that contrast dye shows up under X-ray, and we can see how open or patent those coronary arteries are. This is just a little bit more about cardiac auscultation or echocardiography. So again, a ultrasound imaging of the heart itself. Electrocardiography is the most widely used diagnostic test to look at things like structure and function of the heart using ultrasound signals. So the picture kind of shows all the different structures. On ultrasound, the heart is kind of like flipped upside down. So the ventricles go to the top and the atrium go to the bottom, and then the valves kind of in between. If it's a live picture, you can see like the valves like opening and closing. You can see that heart muscle kind of contracting. So we look for things like, are all of the areas around the heart muscle contracting equally, or is there like a whole side that's just kind of sitting there? Are the valves moving like they're supposed to? All kinds of things you can see when you look at echocardiography. Okay, so a little bit more about some classifications of coronary heart disease. We kind of have two broad classifications and then some subclassifications underneath. So we have what we term chronic ischemic heart diseases. These are things like chronic stable angina, silent myocardial ischemias, and something called variant or vasospastic angina. And then in the acute coronary syndromes, or ACS, that is unstable angina, non-ST segment elevation MIs, or NSTEMIs, and ST segment elevation MIs, or STEMIs. So we'll talk more about each. So now we'll talk about stable versus unstable plaques. And so these are atherosclerotic lesions or plaques within the coronary artery disease. We already talked about how atherosclerotic plaques form and how they can begin to cause damage throughout the body when they occlude arteries. And so this is going to be a conversation specific to what we see in the arteries that supply blood to the heart when they develop atherosclerotic plaques. So there are two types, stable and unstable. So when we're talking about stable or fixed plaques, these plaques obstruct some level of blood flow through the coronary arteries. These are the types of plaques that are associated with what we term stable angina. And so you can see in the pictures, in the first picture here on the left, you see a normal coronary artery, no plaque formation on the inside of that artery, and a completely open and patent lumen. If we move forward a little bit, you see a coronary artery that has started to develop a bit of atherosclerotic plaque, but we term that asymptomatic. And so at this level of plaquing, this patient, despite some obstruction to that lumen, is still maintaining adequate blood supply to the myocardium, both at rest and during increased workload, and so they wouldn't experience any symptoms of that plaque formation. As that plaque progresses, it may become what we call a stable fixed atherosclerotic plaque that you see here, again associated with stable angina. We still have a significant portion of that lumen that's open, that plaque is stable and slow growing, and so we maintain that portion that is open within that lumen. But the other type of plaque that can form is an unstable plaque, or a vulnerable or high-risk plaque. What makes these high risk or vulnerable is because these plaques can actually rupture. And when they rupture, it's like forming a kind of new lesion inside of that blood vessel. And so platelets that are floating past react to that lesion by starting to stick to it and aggregate to that site. And as they further aggregate, we can start to see things like thrombus formation within that vessel. And so as that disruption starts, we might see unstable angina where that patient has chest pain both at rest and at increased work. As that thrombus might progress, someone may experience what we call a non-ST segment elevation MI, which we'll talk about. But you can see there's still some lumen open, so they still have a certain degree of blood supply. And then the thrombus progresses further to where it completely occludes that coronary artery, and that would block all blood supply and all oxygen supply to the portion of the myocardium downstream from that thrombus formation. And so if we're completely occluded, that's usually when we see things like ST segment elevation MIs, which we'll talk about. So we'll start our coronary artery disease discussion with the chronic ischemic heart diseases. So these are things like chronic stable angina, silent myocardial ischemias. Another condition is something called vasospastic angina, which we're not going to really talk about here. That is when the arteries that supply the blood spasm for some reason. So the arteries themselves are clear, no plaquing formed, but when they spasm, they temporarily cut off some blood supply. But that's really all I'm going to mention about that. We're going to really focus on stable angina and the potential for silent myocardial ischemia. So within the types of angina, chronic stable angina is associated with those really fixed coronary obstructions, those fixed plaques that start to produce this disparity between coronary blood flow and the metabolic demands of the myocardium. So usually with stable angina, that means that there's potentially pain in the chest, that anginal chest pain, but only at times of increased myocardial workload. So maybe during exercise or other times where the demands on the heart go up. And stable angina is usually relieved by rest. So if someone sits down or removes themselves from the environment that's causing angina, it should be relieved relatively quickly. Stable angina is usually the initial manifestation of ischemic heart disease in approximately half of people with CAD. So while we call it chronic, while we call it stable, it can be obviously a kind of um, warning sign that there is some degree of coronary artery disease that's developing, and this person probably needs further evaluation to determine the degree of coronary artery involvement. So some people also experience what we call silent myocardial infarctions or myocardial ischemia. And these are people who are asymptomatic without any other evidence of coronary artery disease. Um, some people who have had myocardial infarcts continue to have episodes of silent ischemia. Um, And people with angina also have episodes of silent ischemia, meaning sometimes they might experience angina and other times they might have a lack of blood supply to the myocardium that doesn't manifest itself with angina. And so essentially, again, what this silent myocardial piece means is that these patients are experiencing underlying myocardial ischemia. There is damage happening to the myocardium, but they don't experience that sign of angina with this ischemia. Um, we understand that a significant portion of people who do experience ST elevation myocardial infarctions um, are older people who do not experience any sort of angina. It's unclear why this phenomenon happens, why some people don't experience angina or chest pain while they're experiencing ischemia, but many people don't even realize they've had a heart attack until they come in for maybe some other procedure, and we do an EKG and see changes, and then maybe do structural exams of the heart and find areas that clearly have had ischemia or cardiac cell death. So for patients with chronic or stable angina, these are some of the treatments that we might use to relieve or alleviate those symptoms. There are a lot of pharmacological agents that we can use in this space that you'll talk about in pharmacology. But essentially, the treatment goals from a pharmacology standpoint, when we're trying to treat someone for angina, are number one, to try to increase the blood flow through the coronary arteries, whether it's to stabilize plaques, whether it's to increase the movement of blood through those arteries, prevent thrombosis formation, whether it's to give a medicine that will maybe dilate those vessels, anything we can do to increase that blood flow through the coronary arteries. And then the other major goal of treatment with medication management here would be to do things to reduce workload on the heart. So maybe a beta blocker to lower heart rate, something to block sympathetic nervous system activity so we don't get that increase in heart rate and contractility. Anything that could potentially reduce preload or afterload might be used to prevent angina. But again, you guys will talk about those things in pharmacology, but I encourage you to really think about them in terms of how they would help someone manage angina, which again is really just angina as a warning sign that we have a mismatch of oxygen supply and demand. But some non-pharmacological treatments, one is smoking cessation. So anyone who smokes and is experiencing angina needs to be encouraged and assisted with smoking cessation. A regular exercise program can also help to start to alleviate some of that angina. Weight reduction, if a patient is obese, can be helpful. Stress reduction, also making dietary changes, especially lowering intake of cholesterol and saturated fats. And other things like avoiding really cold environments or other stressors that might produce vasoconstriction. That vasoconstriction can precipitate episodes of angina. So those were the stables. Now we're going to move on to acute coronary syndrome or ACS. And this includes unstable angina, non-ST segment elevation myocardial infarctions, NSTEMIs, and ST segment elevation myocardial infarctions or STEMIs. So we'll start with unstable angina. And unstable angina is essentially pain in the chest that occurs without activity, meaning it can happen at rest or it isn't alleviated by rest. So maybe somebody's out shoveling the driveway and they get chest pain, so they sit down, but the pain continues. That would be considered unstable angina. Okay. So a lot of the basis for diagnosis here is really based on pain severity and presenting symptoms. What were you doing when the pain occurred? What did you do to try to alleviate it? Um, did it work, right? Other things we might look for, hemodynamic instability. If someone is experiencing chest pain and they're experiencing significant, alterations in their blood pressure or heart rate, that might be more concerning with unstable angina. A major piece of diagnostics during unstable angina is EKG findings, as well as serum cardiac markers. And so we're going to talk about both of those really important diagnostic tools in ACS. So with electrocardiographic changes or EKG changes, this is the diagnostic tool that often initiates whatever treatment we feel is necessary for acute coronary syndrome. So some of the changes we typically see on EKG are potentially things like T wave inversion, abnormal Q waves, but the big thing we're often looking for is this ST segment elevation. And I know you guys haven't done much with EKG yet. We'll talk about it a bit in this class, but you can see in the picture, this is a normal EKG tracing. It's reading the electrical activity through the heart. And when someone experiences a heart attack, the portion of that EKG tracing that we term the ST segment, that goes essentially from right here to right here, starts to elevate. So you can see where it is at baseline on this tracing, and we're well above that baseline in the second. So that's what we mean by ST elevation. If someone comes in with unstable angina and we do an EKG and this is what we see, that person needs immediate treatment for this acute coronary syndrome that they're experiencing. And so that's why EKG is so important in these diagnostics, because we get immediate results. And the treatment for ACS is often very time sensitive, meaning we need to restore blood flow to that cardiac muscle immediately. We don't really have time to wait for other kind of lab tests or echocardiograms or any other kind of test. This really gives us some of those immediate results that we need. The other important diagnostic finding is serum biomarkers, and there are two of important clinical significance, and they are troponin and creatinine kinase MB, or CKMB. So these serum biomarkers are formed when intracellular contents of myocardial cells are released when those cells become ischemic. And as they're released, they end up in the bloodstream and then they show up on our testing. So if someone has a plaque or a thrombus that has formed in their coronary artery and it has caused significant ischemia or loss of blood supply to the cardiac tissue, those cells become injured or die and they release their contents. That ends up in the bloodstream and we can find these biomarkers. So these are indicators that there has been damage to the heart muscle itself. If someone comes in with angina and their EKG is normal, and then we get serum biomarkers and their biomarkers are negative, it just means that person is experiencing chest pain, but they have not experienced any damage to their cardiac muscle. But if these are elevated, it means there has absolutely been some level of damage to the heart muscle. Troponin usually goes up first, and it's the most significant and specific biomarker of cardiac cells. CKMB rises later. It's also pretty specific for cardiac markers, but doesn't go up as quickly as troponin, and it comes down more rapidly than troponin does. Troponin can remain elevated for even up to 7 days post-MI, and we often follow these serial troponins while someone is hospitalized to kind of gauge the extent of damage. The higher that these troponins spike, the more cardiac damage we can assume has happened. So what causes angina to become unstable? Well, as you recall back to the picture with our stable versus unstable plaques, one big reason this might happen is because one of those atherosclerotic plaques within the artery may have become disrupted, and that leads to a certain amount of platelet aggregation to that site, and some secondary hemostasis or slowdown of that blood flow through the coronary arteries. And again, this is why, many times stable angina is a sort of warning sign for the potential of unstable and ACS. Again, because if we have plaque disruption of a stable plaque, now we're moving forward kind of in that cascade. So some characteristics or what pain associated with unstable angina looks like. So the pain has a more kind of persistent and severe course than stable angina and is characterized by at least one of these three features. So these are important to be able to distinguish stable angina versus unstable angina, which is a more serious condition. So unstable angina can occur at rest or with maybe minimal exertion. It usually lasts more than 20 minutes in duration. Another characteristic that may be present is that the pain is very severe and is described as frank pain with a very new or abrupt onset. And the final criteria that might be there is that it occurs with a pattern that is more severe, prolonged, or frequent than previously experienced. So if we have a patient who maybe has experienced chronic stable angina in the past, this would feel very different for them. It would be much longer in duration. It would be much more severe. It would just feel different than their typical course of chest pain. The other thing I would mention with rest, we also consider the administration of nitroglycerin to be a form of rest. So you guys will learn about nitroglycerin in pharm, but many patients with stable angina carry nitroglycerin around for treatment. And if they take their nitroglycerin during an anginal episode and it doesn't relieve it, just like they couldn't relieve it with rest, that might also be an indicator of unstable angina. So unstable angina can then progress into what we call a non-ST segment elevation myocardial infarction. So this differs from unstable angina because now if we tested serum biomarkers, they would be detectable. We would have elevations in troponin, maybe in CKMB, so we would know that it wasn't just pain, that we actually had some ischemia occurring that damaged those cardiac cells. In NSTEMI, there's been ischemic damage to the cardiac cells leading to elevation in biomarkers. But what they don't have is any of the characteristic EKG changes that we see in an ST elevation MI. So that ST elevation on EKG is not present for these patients. So they might come in with unstable angina, their EKG is negative, so then we move on to checking serum biomarkers. If those serum biomarkers are positive, then we would diagnose this person with an NSTEMI. So now we'll talk about kind of the next step in this progression, which is an ST segment elevation AMI or acute MI. So this type of myocardial infarction usually has a very abrupt onset. The most classic signs of this are a severe and crushing chest pain. It's usually substernal or it can radiate to the left arm, neck, or jaw. Know though that these are the typical signs. And so some patients have sort of more atypical signs. They might experience more back pain. They might not experience, significant chest pain at all. So we see that maybe in diabetic patients. We sometimes see that more often in women. So some of these classic symptoms are not always present. Another thing that we typically see are maybe gastrointestinal complaints like nausea and vomiting. Many of these patients, if you see someone who's having an acute MI, they're usually really pale and diaphoretic. Their skin is really cool. I'm just picturing picking up patients from the ER looking sick and hanging over a bucket and throwing up and just experiencing all this pain. They just look really sick and uncomfortable. Other things are significant fatigue and weakness. Things like tachycardia, anxiety, and restlessness can also occur. And sometimes you get this sort of patients who are reporting sort of this like feeling of impending doom. They just know something bad is going to happen. Those are really significant signs in diagnosing the presence of an acute MI. So in the picture here, you can kind of see a few things that I'll point out. In the first graphic here, you see a normal EKG, and you see an artery that has maybe some plaquing, but otherwise it's got good blood flow. And this is what happens when we have an ST elevation MI. So you can see that massive elevation in that ST segment. We used to call these tombstones because instead of this little narrow triangle, they would get to be these kind of like wide and bizarre looking ST segments. And so you can see how that translates to what's happening in the artery. That plaque is ruptured and a thrombus has completely filled that artery with no blood flow downstream. And so in the picture of the heart, you can see that occlusion is way up here. And so all of this tissue on the myocardium is now experiencing ischemia. And so the goal of treatment is to get that artery open as quickly as possible and restore that blood supply before that damage is permanent. And so this is where you start to see, this shows a little bit of the treatment too. And so now here's your thrombus and your plaque. This is a balloon that has been inserted into that coronary artery. We're going to inflate that and push everything up against the artery. And so we're starting to kind of open that and restore some blood supply. So you can see in the picture here, we've still got a little bit of ischemia, but we're starting to see a little more perfusion. Our ST segments are coming down, and then we will leave kind of a stent behind to hold that open. And so like a further kind of disruption of, or further lowering of our ST segment and better kind of perfusion once that happens. So this is an angiographic kind of picture of different, of some stenosis. This person has some pretty severe multi-vessel disease. So this is the left main artery. You can see a significant stenosis there. You can also see in the left anterior descending, there's multiple areas of stenosis. In the circumflex, there's some stenosis. This is what we call like the widowmaker because you can see how much will be destroyed by that. This is probably a patient who would most likely be sent for coronary artery bypass surgery just because of the extent of the disease in general. That's just way too much usually for treatment with ballooning and stenting. But this picture leads to kind of this conversation about different factors that determine the extent of infarct. A lot of the time it's the location and extent of the occlusion. So if you have occlusion way up here, you are going to have a massive and extensive infarct. And that's, again, why we call it the widowmaker. If that happens really suddenly, these folks often don't even make it to the hospital because they have such a massive interruption of blood flow that they can't survive it. Their myocardium is just essentially too stunned to even perfuse. And so that really speaks to, again, the amount of heart tissue that's supplied by the vessel as well. That it really determines the extent of the infarct. Another thing is the duration of the occlusion. So if I look at this picture, one thing that I see is kind of all these sort of little vessels sort of branching off all over the place. And that makes me think that this occlusion has been kind of slowly cooking for a while. It wasn't really abrupt, especially kind of right here and right here. We call that collateral circulation. And so as these arteries start to slowly close, your body starts to develop kind of other circuits of blood flow to keep that the blood supply adequate to the myocardium. So if people slowly stenose over time, they actually do better if they get arteries that close because they still have a lot of collateral circulation. But people who have really abrupt occlusions and don't have all of this collateral blood supply development have more severe extent of infarct because it's essentially just all their blood supply lost at once. And so that's kind of the duration and also this discussion of the extent of that kind of collateral circulation that happens. Other things are the metabolic needs of the affected tissue. So when patients come in with ACS, one of the goals of treatment is to really reduce the metabolic needs of the tissue. We really want to reduce the workload of the heart because the more metabolic needs, the more extent of injury there will be. And so you really want to try to reduce that significantly in a patient. And so things like heart rate, you want to bring down. You want to lower patients' blood pressure so the afterload is lower. You want to make sure that they're staying in a good and adequate cardiac rhythm to make sure that there's good filling and emptying based on that electrical drive. So when someone has an infarct, there's a certain degree of medical management that we follow with an infarct. This includes a lot of medications as well. There's a lot of medication management that happens here, but again, you guys will really talk about that in pharm in relation to how do we reduce workload, how do we improve coronary circulation, what drugs do we use when we're performing different interventions on the heart. So again, really be thinking about this piece when you're having that conversation about meds, thinking about why these medications are helpful before, during, and after an infarct. But one medical management piece might be something called thrombolytic therapy, where we administer medications that are meant to break up or dissolve clots. But there are other what we call revascularization interventions. So one is coronary artery bypass grafting or CABG, and that's an open heart surgical procedure where we take a blood vessel, oftentimes large veins from the legs, and we reestablish blood flow. And so you can see that here. This is a bypass graft, kind of that light pink, and over here, this is a bypass graft. And so we'll attach one end of that graft to somewhere on the patient's aorta, and then we'll reattach it to the coronary arteries just past wherever the occlusion is to restore blood flow to the rest of the heart. And the other intervention is percutaneous coronary intervention. And this is where we go through the skin, usually into the femoral artery, but you can do it from the radial artery, anywhere where you have arterial flow. And we insert balloons and stents into the coronary arteries that push those plaques up against the wall and restore that blood supply. There's also something called arthrectomy. That's a kind of a high speed kind of rotor catheter that sort of whips around inside of the artery to break up all of that plaquing. While it's breaking it up, we're also instilling usually some saline solution along with some kind of suction to be pulling out those chunks of plaque as we break them up. The most common thing we do, though, is PCI, or with more extensive plaquing, we might do a CABG like we saw in the previous angiogram. And after all of this intervention, once someone is stabilized and maybe outside of the hospital, we would start them as soon as possible on something like a cardiac rehabilitation program to start rebuilding any of that heart muscle that was damaged when they had the heart attack.